I've got 94 slides, so that's 3 slides per minute. So God help me. So right, if you guys, if I'm too fast, you can always go back to our CPD guidelines for 2016. This is freely available online. So these are some statistics which I will skip. And what are the objectives of our lecture today? All right, first of all, we're going to try to recognize cardiac diseases in pregnancy, pre-conception counseling, identifying high-risk cardiac patients, and to manage and refer appropriately. So how do we approach cardiac diseases in pregnancy? First of all, we need to know what are the physiological changes in pregnancy. This will help us in systemic, how to manage the patients and also to recognize which are the diseases. Systemic approach to cardiac lesions, we have to monitor the principle of monitoring and treatment, and finally individualizing treatment to each patient and cardiac condition. So what are the physiological changes? I will not go too much in detail because this is quite basic. You normally divide it to 3 different stages, right? Changes during normal pregnancy, changes during labor, and very importantly, also changes during postpartum. I think I will skip the details about what the changes are because I think this you can all read. So this is another graph to show us what are the physiological changes. And physical findings and changes seen in common cardiac investigations in normal pregnancy. So peripheral edema, tachycardia, bounding pulses, these are all the common things that you can find. Apex being shifted laterally, ejection systolic murmur, this is due to your hyperdynamic circulation, high intensity second heart sound. So on the ECG, you do find tachycardia, you do find ventricular ectopics, all right? These are not very pathological. Minor T-wave changes, we always get almost breathless, O&G MOs calling us, the patient is having T-wave changes and all that, V1, V2. These are very much physiological actually, okay? And on echocardiogram, you actually find an increase in the left and right ventricular and diastolic dimensions compared with the previous echoes. And the left ventricular mass may be increased. So what are the symptoms? It's almost a bit difficult to distinguish from normal pregnancy. So you have reduced effort tolerance, tiredness, autopnia, palpitations, syncope, dyspnea. And the signs can be hyperventilation, peripheral edema, you get crepitations and distended neck veins. So how do we classify those patients? Because if you look at the signs and symptoms, almost every other pregnant lady would seem to have cardiovascular disease. So very important is this WHO classification, which sort of classifies the percentage of mortality according to the classes. Right, so you have the WHO class 1. So these are those patients with uncomplicated pulmonary stenosis, PDAs, VSD, even mitral valve prolapse, and successfully repaired simple lesions. And you have isolated PVCs and atrial ectopics. The class 2 are those which have a moderate increase in maternal mortality. They are the unoperated ASD and VSD, which are less than 4, repaired TOFs, and asymptomatic arrhythmias like your WPWs, AFs, and SVTs. You also have the class 2 to 3, which are those patients with mild left ventricular dysfunction, HOCM, Marfan's without aortic dilatation, and native or tissue valve disease, not considered WHO 1 or 4, and mild repaired coaptation of the aorta. So you have your class 3, which have significant severe increase in maternal mortality. These are those with reduced ejection fraction, those on mechanical valve, systemic right ventricle, Fontan circulation, CHDs, congenital cyanotic heart diseases, yeah? And those with aortic dilatations. Now these are the cases that we normally manage in our center in combination with the O&G team. And you have those in class 4 which have a very high maternal mortality, almost half. Those are with a severe pulmonary arterial hypertension, severe systemic ventricular dysfunction, and history of previous peripartum cardiomyopathy with residual impairment, okay? You get a large group of them without. So these are those with residual impairment, severe MS, Marfan's, and those with aortic dilatation and uncorrected coarctations. So the class, this is about a reputation, this is your NYHA classification, which is very important, and this is another way that we risk stratify the patients. Those with class 1 and class 2 is at low maternal cardiovascular risk, class 3 and 4 are high maternal cardiovascular risk. So this slide tells you how to follow up the patient, the timing of specialist referral. I think those who are from district hospitals, these are quite important. So class 1 and class 2 should be seen at least once at the local specialist center. Class 2 to 3 to 3 is early referral to a cardiac expert center. And class 3 and class 4, you need to refer for preconception counseling, urgent referral if you discover this patient is pregnant, and multidisciplinary team management. Okay, so I will skip this slide because I think it's very much in detail. So now I'll go to preconceptual counseling. So if you discover a patient with class 3, class 4, you should actually start preconceptual counseling. Actually, it's mainly done here. And what we do is we talk about the effect of hemodynamic changes, effect on fetal development, effect on maternal drugs and features, risks of genetic transmissions, and compliance to follow up. We also advise them to complete their family early, discourage from multiple pregnancy, high-risk patients, they have to go for permanent contraception, and another line I would add is a proper spacing of pregnancy. Recurrent congenital heart lesions in the fetus of parents with congenital heart diseases, normally the ones that you see commonly are ASDs. I think the rest is okay. So now cardiac diseases in pregnancy, the non-cyanotic cardiac diseases with a good functional class, normally the fetal mortality is quite low. However, the cyanotic cardiac diseases have a very high risk of fetal death, and you also get low birth weight and immaturity. So now I'll just quickly go through a case presentation. 24-year-old G2, 24-year-old G2 P0 plus 1, 12 weeks period of amenorrhea. She complained of worsening reduced effort tolerance and shortness of breath with PV bleeding, denies past medical illness, and very importantly on physical examination you find her to be club sinus. There is a fixed split of the second heart sound, and you get a systolic murmur at the lower sternal edge. The SpO2 is just about 84% under room air. Anybody? Diagnosis? Yeah, I can hear some whispering. So further investigation showed ECG showing RBBB, and correctly, as some of you all whispered, the echo showed the ASD secundum type, alright, with right to left shunt, hence patient being cynosed. So a little bit about cyanotic heart disease again. The overall maternal mortality is 2%, with high-risk complications such as IE, arrhythmias, congestive heart failure. Fetal prognosis is also very poor, and higher risk of premature delivery. Pregnancy is not recommended for this kind of patients, and if pregnancy occurs, termination should be advised. And having worked in the north of Malaysia for a long time, most of them do not take our advice. So if they continue with the pregnancy, what will be our management? Physical activity should be restricted. Bed rest is recommended if symptoms occurs. Oxygen should be given if there is hypoxemia. Patient should be hospitalized by the end of the second trimester. Low molecular weight heparin should be started, and prophylaxis against thromboembolism, particularly in a cyanotic heart disease patient, should be commenced. So high-risk cases where we counsel the patient for termination of pregnancy in early gestation period would be pulmonary hypertension, Eisenmenger, cyanotic heart disease, poor EF, and Marfan syndrome with a significantly dilated aortic root more than 4 centimeters. And these are the cases that should be corrected before pregnancy: congenital defects, severe MS, severe AS. Quick note about congenital defects. Even in Alor Setar, those patients with small ASD and VSD, we actually have workshop to close these lesions, and it is no more done through an operation. It's actually just done through a transvenous femoral puncture. And with severe MS, you also can close it at Penang GH, where they use a PTMC, once again transvenous. So it's not necessarily an open heart surgery like those days. So how to detect cardiac diseases in pregnancy? I think most of you do a very good job in this. So careful history and physical examination, symptoms, NYHA classifications, and any significant past history. Okay, so once again, NYHA classification is very important. I will not go through it again. And it is also important to distinguish the physical examination, because you find if it is abnormal in a non-pregnant state, it can be normal in pregnancy. So what are the things to look for carefully in a pregnant lady? Clubbing and cyanosis, arrhythmias, and you have to monitor you have to look at the BP and raised KVP, any significant murmurs, right ventricular heaving, and loud second heart sound. So basic investigations are ECG and echocardiogram, and we already have a very, very low threshold for you guys. Risk stratification is important. Once again, your NYHA functional class. And you also look at cyanosis. That means it shows that there's right to left shunt. LV and RV functions, pulmonary hypertension severity, stenotic lesions, and conduction defects or arrhythmias. So now let's go through another case. 32-year-old G1P0, 15 weeks period of gestation, diagnosed to have severe mitral stenosis with an MVA of 1 centimeter. She was asymptomatic at this point, and what should I do? Any takers for termination of pregnancy? Just a raise of hand. Okay. PTMC. As I told you, we can do PTMC in Penang. Repeat serial echo. Initiate beta blocker, or just reassurance. So we just go through the expert consensus on management of cardiovascular diseases during pregnancy. Close follow-up is necessary in every pregnant woman with severe MS, even she was totally asymptomatic before pregnancy or during first trimester. The mean transmitral gradient and pulmonary artery pressure should be measured by Doppler echocardiography at 3 months and 5 months. So we actually monitor the patient first. 1 centimeter is actually borderline between severe and moderate. If the same patient develops worsening shortness of breath, fatigability, edema, what is your next? What are you going to do next? So do you now start your medications, which are diuretics, beta blocker, PTMC, repeat the echo again, or reassurance, or TOP? Well, yes, medical treatments with beta blocker should be started in patients having symptoms or high systemic pulmonary artery pressure. Choice of selective agents such as atenolol or metoprolol limits the risk of interaction with uterine contractions. Adjustments of those should take into account mean gradient, pulmonary artery pressure, and functional tolerance. High doses are frequently required by the end of pregnancy, and diuretics need to be added if significant pulmonary congestion persists. And if the patient still has symptoms, despite medical therapy, there is a high risk of pulmonary edema at delivery, and hence probably a CCU backup will be needed. So low-risk pregnancies are normally generally well tolerated, uncomplicated septal defect, mild to moderate pulmonary stenosis, regurgitations, murmurs, which are very much well tolerated in pregnancy and are considered low risk, HOCM, acyanotic abnormality, and corrected transposition. Moderate risk would be the coarctations, prosthetic valves on anticoagulations, and univentricular circulation after a Fontan operation. And your referral should be to a tertiary center for high risk. Moderate risk should be hospital with specialists, and low risk probably just your clinic. So early specialist referral should be for cases with known heart disease, prior cardiac surgery, non-risk stratified prior to pregnancy. Moderate or high risk, worsening symptoms due to heart disease and suspected heart disease. Management and follow-up, assess maternal and fetal health, NYHA functional class, confirm clinical diagnosis, baseline hemodynamics, anemia and infection should be investigated and treated appropriately, high-risk cases for TOP. So what are the complications of heart diseases? You develop heart failure, which can be managed with diuretics, digoxin, nitrates, and hydralazine. You have to avoid overdiuresis, as this will cause hypovolemia and hypoperfusion. Worsening right to left shunt. Now this is the most worrisome, if you ask me, and this causes increased hematocrit, reduced SpO2. So basically, we just give nasal bronch oxygen and adequate hydration. Thromboembolism and arrhythmias are the other complications. All right. So another quick case, you have a primary 16 weeks mild SOP, fatigability, no edema. She's got underlying severe AR. So BP shows a white pulse pressure, pulse rate 100, ED matters. ECG showed left ventricular hypertrophy. Echo showed thickened AV walls with severe AR flow. And LV chambers are dilated. Okay. So how we manage this patient? Increasing in blood volume and cardiac output will increase volume overload consequent upon the valvular regurgitation, but decrease systemic vascular resistance, hence reducing the regurgitation fraction, which compensates part of this. So in AR, the shortening of the diastole consequent of tachycardia contributes to reduction in the regurg volume. This explains why pregnancy is frequently well tolerated in patients with severe wall regurgitation. So hence I said earlier, the regurgitation wall abnormalities are much better tolerated in pregnancy. Having mentioned that, patient may still develop progressive heart failure, particularly during the third trimester. Diuretics plus vasodilators can help to reduce the afterload unless the BP is low. ARBs and ACE are contraindicated, and the other options are dihydropyridine CCBs, and vaginal delivery may be carried out safely. So hence they need to be admitted for close monitoring, especially for overload, and we can judiciously use diuretics unless patient develop hypertension. I'm definitely not going to go through this. And this can be read. Basically, these are the considerations and WHO risk stratifications for specific congenital heart diseases. So it's one by one. It's quite detailed for the common ones. So you guys can go through it in our local CPTs. Right. Comparison of maternal mortality.